obesity is very complex, and it is not the same in every person who has it. So it's very heterogeneous. Somebody may look the same on the outside as another person, but they may have entirely different underlying physiology or pathology that got them there. And so that's important to understand too. And that's why there's no one size fits all for treatment either.
Hello, everyone, and welcome back to the Thick Thighs Save Lives podcast. I'm Kelsey.
Welcome back, guys. I'm Rachel. We have a very special guest for you today who is going to answer all of the burning questions that you guys asked us in our Facebook group, on our app, on Instagram. You had lots of questions surrounding weight loss surgery, and we have the expert here for you today. So this is Teresa LaMasters, who is currently the medical director for bariatric surgery. You are at UnityPoint Clinic Weight Loss. Is that still accurate?
Yes.
And you're in Des Moines, right?
Correct. Yes.
So she is an absolute expert when it comes to all things weight loss. She has, she's not only a bariatric surgeon, but she's also a clinical associate professor. She has done over 4,000 surgeries in her 17 years of practicing medicine, and also serves as the senior past president for American Association for Metabolic and Bariatric Surgery, which is really the premier organization for bariatric surgery worldwide. So we brought you the best, and she is here to get rid of some stigma and answer some of the questions that we all have surrounding this medical decision. So welcome, Teresa.
Thank you. Thank you for having me. I'm excited to be here.
Yeah, Teresa, we're really excited to have the expert on here to just kind of like let us know like what's going on in this space. We have a lot of women who have put their health and fitness, at their top priority and have found some barriers to achieving and living their best, happiest, healthiest life. And in a lot of ways, you're helping solve a lot of those problems. So can you tell us a little bit about your background and like what led you into this field?
Sure. So my personal story is that I come from a family that doesn't have doctors, but my mom was a nurse and my dad was a mechanic. And my big joke was that what do you get when you mix a nurse and a mechanic? You get a surgeon. So that's kind of my big joke from my background. But really, I decided that I wanted to go into medicine as a sophomore in high school, but I had no idea how to get there. And so I did a lot of things to get there, and by serendipity and hard work, I got there. And once I was going down the path of surgery, I ran into bariatric surgery. That wasn't my planned specialty, I would say. In my residency, that's where I had exposure to bariatric surgery and started to learn a little bit about it. And then after my general surgery residency, I did a fellowship, which is special training in the area of metabolic bariatric surgery, robotic surgery, and what's called minimally invasive surgery. And so I did a lot of different kinds of surgery, but a heavy emphasis in bariatric surgery. And then I came to Iowa. So I came from California, Stanford, to Iowa, and that's where my husband's family was, and it was a great place to put down roots and raise a family and start a practice. So I have been in Des Moines, Iowa for a very long time, actually, and I really built the practice kind of from dust and to a very successful, healthy program and practice. I have a great team I work with. I think that's really important to understand, is that we work in teams. It is not just the surgeon. I have 4 fantastic dietitians. I have an exercise physiologist, mental health professionals, specialty nurses. I have 2 wonderful partners. We have 4 advanced practice providers, which are PAs and nurse practitioners. So we have a lot of people in the team helping because we really are committed to lifelong care of people suffering with the disease of obesity. So I actually am double board certified, both in surgery and in obesity medicine. So I did my obesity medicine boards a little bit later. I got very interested in the physiology and the hormonal aspect of obesity, and understanding the gut-brain connection that happens with obesity. And really understanding of our metabolic bariatric surgery has expanded dramatically, I would say, in the last 10 years, especially, and understanding better what we're doing. You know, in the old days, a lot of people really looked at it as forced restriction, that we were forcing people to eat less or not absorb their calories. And what we found is actually that's a very small piece of what's going on. And what we're doing is we're altering biochemistry, we're altering gut hormones that connect directly to the brain. And some of these hormones are directly brain interactions. So what we're doing is much more complex. And actually, the restriction or the malabsorption part is a very, very small role. But despite our knowledge in this area, I think that the wider public has very, very little knowledge about the disease of obesity or the treatment options, what's effective. There's a lot of stigma. You mentioned stigma. There's a lot of stigma around this disease. Most of the general public doesn't understand it as a disease. They look at it as a character flaw or willpower problem. And if people would just try harder, they wouldn't have this problem. And what we know is science says otherwise. And then there's a lot of science behind this, actually. So I really have a passion of helping educate people, of course, people who are patients, but also the public about what this disease is and that there are effective treatment options for this disease. And it's not about a number on a scale. And I think both of you are well aware of things like that. That it's really about health and the fact that this disease causes people to die much younger and impacts quality of life, and it creates a great deal of disability. And we can treat that. And I think that's just not well known, despite how much science there is about this. And part of that is related to the bias. So my example for this is understanding like mental health issues. So years ago, mental health issues were thought to be really the person's own fault. It was highly stigmatized. The people who took care of those folks were highly stigmatized. As we started to understand more that it was a biochemical problem and there were better treatments available, then people started to recognize it more as a disease process, a medical problem that should be treated. And then we moved into the realm of you should advocate for yourself. You should be getting treatment, and we should be talking openly about this. This should not be something in the shadows. That's what we need to do with obesity. It is still very much in the shadows. Even people who have done extremely well with treatment are very hesitant to talk about that treatment because they feel like people approach them as, well, you took the easy way out, and like somehow they cheated, instead of like understanding that they have a health issue that can and should be treated so they don't die young from a heart attack, a stroke, cancer. They should demand treatment for their health problem that is a life-threatening health problem. So that's really kind of where my background and my passion comes from. I am a national leader in our society, but I've done a lot of coaching and teaching nationally, internationally. I also do a lot for the American College of Surgeons. I am the vice chair for our accreditation program around the country. I help write the standards. I review programs. I do quality improvement coaching. So I do a lot on the surgery side, but I do a lot on the medicine side too. And we've been prescribing medications really in our office probably since about 2010, 2011. So long before the current excitement and wave came, we've been treating this both medically and surgically, and understanding the synergy between those two things as well. So I could talk for a long time, but I want to leave it open to you guys so we can make sure we get the questions answered.
Well, I think that that's a really great opening. And obviously, we can deep dive into some more of those topics, which I think are going to be well sought after from our audience. But I also just want to mention talking about obesity as a disease is something that I've gone back and forth on because I personally, and I would be remiss if I didn't say that I was hesitant to do this episode because I personally find it difficult to walk the line between body positivity and health at all sizes and obesity as a disease. I find that although there's so many intricacies to both of those, they sort of get you're either one or you're the other. And I wanted to give you a chance to talk about some of the more recent research that suggests that not only, are there genes that are attributed to obesity, but also that, health at all size, really emphasis there is health. And if there is an issue with health with regards to body fat percentage, that is in fact a medical condition.
Yeah, so that's a lot to unpack there. So we'll get started, and then you might have to remind me as we go, because really, I mean, that touches on so many of the areas we need to talk about. So first, talking about obesity as a disease. So first, understanding that obesity is very complex, and it is not the same in every person who has it. So it's very heterogeneous. Somebody may look the same on the outside as another person, but they may have entirely different underlying physiology or pathology that got them there. And so that's important to understand too. And that's why there's no one size fits all for treatment either. So an example of this is like cancer. Okay. Cancer is not the same depending on which organ you have, which stage you're at, and what your genes are and what your receptors are. All of that makes a big difference. It's not just cancer. So like even in breast cancer, right, there's invasive ductal carcinoma that's very different from other lobular carcinoma. It depends on if you're PR/ER positive or negative, and those things impact your treatment. And it's very tailored to, you may get pre-surgery treatment, which we call neoadjuvant therapy, and then you get surgery, and then you may need adjuvant therapy, which is after surgery treatment, and then you may need repeat therapy for recurrent disease. So this is what obesity is like. It's not linear, and it's not exactly the same in every person. So some people have had obesity really since they were like 3 years old. And that is highly genetic. And in fact, there's certain what we call monogenetic syndromes that occur very early in childhood. And so those folks are a little bit different than somebody who it comes on later in life. Oftentimes we see women after menopause or a hysterectomy have significant body changes and weight changes and health changes. Those are underlying different pathologies. But when we talk about the genetic predisposition of obesity, there are over 160 different genes that are associated with obesity. And some of these essentially are on all the time. That's like those young children who have severe obesity very young. Those genes were turned on before they were born. Other folks, genes can be turned on later in your life. And sometimes they're impacted by environmental factors, actually. And we see this with cancer too, what we call a second hit phenomenon. You may be already predisposed to that, but you may not get it. But sometimes you do, because there's an environmental or some other trigger that can trigger that to turn on at a later point, and then that disease develops. So we see that with obesity too. There are a lot of people who are carrying essentially a genetic predisposition. And some of them for sure are going to go on to obesity no matter what they do. And some of them may not, depending on, again, what factors are all associated together with that. So it's a very complex disease, and therefore the treatment really is necessarily complex. And when people ask me about how can this be a genetic disease, because the obesity epidemic has occurred much faster than DNA can shift in a population. And so the answer to that one has to do with what we call DNA methylation. And that means that, again, usually environmental impacts can kind of change a gene's expression. And so one of the first places this was identified were in women who were smoking during pregnancy. And it caused a DNA methylation that increased not just the chance of asthma for that child, but another generation, 2 generations from the mother smoking during pregnancy. We see that with obesity. So there is communication that happens in the womb for women who have obesity that increases that child's risk of obesity as well as future generations. So it expands much faster than you would see with DNA shifts. And this is also, since we're talking about women's health, which I love, talking about the importance of health coming into pregnancy and really paying attention to those things. So that's a little bit about the DNA background of what's going on. So we look at about 70% of obesity is related to genetics. So it's a high amount. It's not 100%. And the frustrating thing for some people is like, well, my sibling doesn't have any problems with this. How can it be genetics when I have problems and my sibling does not? But guess what? We don't always get the same genes. First of all, we don't ever get the exact same genes. But also, again, those secondary factors to what gets turned on, what doesn't, what genes you got versus your sister, those are different. And so it's very frustrating for people who have this disease because they didn't choose to have this disease. And they work very hard to treat it, but they do feel a lot of shame around it. They feel a lot of blame that it was their fault. And there are many people, and I'm sure many of your listeners can tell you, they have worked on this their entire life. And people constantly treat them like they must be lazy. They must not be trying. And they are trying absolutely. The other thing with that trying is that all of us can try, but of course, we're not going to be perfect every day. And then there's tremendous guilt for those days that weren't perfect. And the pressure put on people with this disease about their imperfect days. People who don't have this disease can go on vacation and splurge and gain 5 pounds, maybe 10 pounds, and work really hard over the next 2 months and get that off. People with this disease can't. And that's what's hard to understand. When they have a bad day, it stays with them a lot longer than when somebody who doesn't have this disease, because their body is not working with them in the ways that it should to respond to that like extra calorie intake, so to speak. Their body doesn't ramp up their metabolism and ramp up other physiologic pathways to help them get rid of that. It actually makes it worse for them. So there's a lot to unpack with that question. Let's talk a little bit more too about what is the disease of obesity. So obesity is the excess storage of fat, and it leads to health problems. And so it's crazy word, excess adiposity. We all need some fat to be healthy. Our bodies need fat. But when it becomes excessive, and it's especially the way it is stored, impacts health. And unfortunately, we don't get to pick always how that weight is stored. That comes from your genetics. So if your genetics say that you store it in the middle, around the waist, it is a much, much higher risk to your health, to your heart, to early death. But you don't get to pick how your body is going to store that fat, unfortunately. So the disease of obesity has to do with, again, the gut and the brain. So I tell people this is a brain disease. And people are shocked. They're like, what do you mean? Are these people crazy? No, not at all. It's the brain that is supposed to be controlling our weight, and a lot of things that go with that, our hunger signals, our satiety signals, our metabolism. All of that is controlled by the brain. And a lot of people don't realize that. Now, it does it through a lot of complex interactions, especially between the gut and the brain. And these hormones and these neurotransmitters, it's super, super interesting. I can talk about that stuff forever. But the point is to understand that this is a problem with the brain, and that the body is supposed to respond in a specific way to things like eating excessive calories, or if we're in starvation mode, there's very specific pathways that the body should follow. With the disease of obesity, essentially, it's like their thermostat is broken. So it's set too high. And so every time they work hard to lose weight, their body has very complex mechanisms to push them back up. And they're usually going to overshoot where they were before. We call that the set point, their body's idea of normal. And so this is the story for most people who suffer with this disease is they lose weight, then they gain it back and with more. and then they lose weight and they gain it back and with more. And that's because of this way, essentially the body is moving the finish line. So here's an example I use with my patients. So say you cut your calories down to 1,500 calories and you lost 20 pounds, maybe even 30 pounds, and you've been working hard and doing great and you're so happy. First of all, most of us, our tendency then is to just relax a little bit. And so maybe you went up to 1,600 calories, not much, just maybe not watching every single little tiny thing. But what happens, and we know this through actually a lot of different studies, is the body and people who have this disease will drop the metabolism. So what happens is now your body says you're supposed to be eating 1,200 calories, but you're actually eating 1,600 calories. So again, what seemed like very little, or maybe you didn't go up at all. Maybe you were perfect and you stayed at exactly 1,500 calories and you started gaining weight. And you went, how can this be? I'm doing literally exactly to the T everything I was doing before. It's because the body changed the finish line. So now you have to reduce down to 1,200 just to maintain that. That's not even to lose. So you can imagine the frustration for people with this disease because you're running a race that you can't win. And it's super frustrating because they will be working their tail off just to maintain. And I hate to tell them maintaining is a win with this disease because this disease is trying to push you up. So maintaining, even for a year or two, is a win. And it is hard work. And it's also frustrating because it doesn't seem very fair. It's not very fair that I have to work my tail off just to be exactly like this. And my friend or my sister eats junk all the time, never exercises, doesn't do anything right, and they're still low weight. That just is so unfair. And I totally get that. And again, it's unfortunate we don't get to pick our genes. And so I tell people, behavior does matter. We are not let free of our behavior, but there is a very limited amount of change you can make with your behavior when you have this disease. It's also hard for people who don't have this disease to understand that because they feel like, well, when I change my behavior, I see a result. It's a direct result. If I work hard, I get a result. That is not what happens for these folks. And so I also give an example of imagine, so this is all controlled by very powerful hormones. So imagine if I told a woman to go home and will yourself to not ovulate. I mean, everybody laughs. They're like, that is the most ridiculous thing I've ever heard.
It's not a good time for me to ovulate. I'm just going to turn that off.
No, thank you.
That would have been a convenient button.
But you just can't will it away, right? No matter how hard you try, you cannot will it away. That is what it's like for this disease. And that is why it's so heartbreaking for the people who suffer with this disease and why they feel so much shame and blame because they're told you should be able to will this away. And they know in their heart they can't. And so it creates this really, and not everybody, but a lot of people, a really bad personal image, regardless of what the number on the scale is, because it's that frustration level. So I may have somebody with a lower BMI who has just the same feelings as somebody who has a very high BMI because of that frustration about not being able to have control over this aspect. I have very, very successful patients who are successful in so many areas of their life. And they're like, how can I make all these achievements, do all these great things, and I can't control this? And that's why, because it is very powerful. And it's these mechanisms in your body are more powerful than your willpower is. So that's a little bit more about the disease of obesity. Now, health at all sizes, I think, is important. We do need to understand it because even with the most powerful, effective treatment we have, bariatric surgery, it's not about bringing somebody to ideal or perfect. And that's really important to understand. So depending how severe their disease was before we treated them, that impacts a lot what their final outcome is going to be. So if they have more severe disease, they're not going to go as low no matter what they do, compared to somebody who had less severe disease when we were operating on them. So that's the other mistake people make, is they look at as surgery as such a last resort option. And actually we have way better results if they would come in sooner. And then most people's biggest regret is that they didn't do it sooner. But again, it's because there's a lot of myths and fear and a lot of things around that. But even if we look at bariatric surgery, we have a lot of discussions about what's realistic, and it's not going to be perfect. And still people will hold on to that. Well, you told me I would get down to 180 pounds, but I want to be 150 pounds. So if I just keep trying harder, I'm going to make 150 pounds because I decided it would be this way. And I totally understand their drive and their desire, but it's helping understand that even with surgery, we're resetting that body's idea of normal lower. I can't get it back to quote ideal or perfect. Part of that disease is still there. They're going to live with that disease their whole life. It's way improved and we're going to control it, but it's not gone. And so understanding that even if the number on the scale isn't perfect, you can be extremely healthy. You can love yourself, love your body, and do wonderful, great things. And it's really not about a number on a scale. So I do hear you about it seems like these are supposed to be in opposition, but they really shouldn't be. The key is understanding that the science behind this says that your risk of death goes up when you hit a BMI of 30. And that's not perfect for every individual. I'm going to tell you that right now. BMI is not the perfect tool. We could have a whole big conversation about that. But that is a screening tool. As a general population will tell you your risk of death related to your weight starts going up at a BMI of 30. It goes up a lot more at 35 and then even a lot more at 40. So when we talk about obesity leading to health problems and early death, that's where it starts much earlier than people realize. And part of that is because our general population has gotten larger over the last several decades, it's become, quote, normal. And so a lot of people think, well, I don't have a problem because I'm not as big as that person. But your body still suffers the health consequences of that. So we're living in a world where children will not outlive their parents. And a lot of it's because of this disease. So understanding that whether 50% of the population has this problem or not, it doesn't mean it's not a problem. And it doesn't mean that it's not going to shorten life. Because that's the other question I get, even from healthcare professionals, because you'll be surprised how little most healthcare professionals know about this disease. So like, how can it be a disease if 30% of people have it or if 50% of people have it? Yeah. It's because of the health consequences and because of that science, the science behind the physiology of what's going on. So hopefully that at least lays some groundwork for your question.
Just a quick interruption to give you some leggings.
Did you guys know we own a legging company?
Did you guys know about this?
We own a fitness apparel company. And if you haven't checked us out yet, we are constantly variedgear.com. We've got the absolute best quality workout gear that you have ever put on your body.
Ever. Leggings, shorts. We have 3 different short styles, 2.5 inch, 5 inch, and 7 available for you guys. Several different bra styles for all of your impact needs. And we want to give you a code today for all the new customers. If you haven't tried out how amazing all of our apparel is, we want you to try it out for 15% off. So we're giving you a code. It's new 15. Apply it at checkout and it will give you 15% off your order. You answered a lot there, and ones that I was anticipating asking, just because like thinking about the BMI and knowing there are so many imperfections in how this is calculated and how we're actually determining obesity as a sense of like a body fat percentage, and thinking about like what has the BMI calculations come to. And we've seen a lot of I guess out of the ordinary maybe, or like stand out specifically with athletes. And if you're exposed to people who are carrying a significant amount of muscle and they're very healthy and they're falling in the BMI range of obese, and you're looking at them and you're like, this is not
Right. This is not a health
that
product.
doesn't match up. Like, my partner at one point had fallen into his calculations had fallen into a BMI of, in an obese range, and he had a visible six pack and was in the best shape of his life. And we were like, we're gonna throw that out and just like keep it moving. But understanding that, looking at, general population and where are the statistics falling, and how can we determine in a more of a general sense of like, where is, our health falling, and how can we kind of determine where someone is going to fall in a range where their health is significantly at risk because of the amount of body fat that they're carrying around on a daily basis.
Right. So you bring up a good point, and this is oftentimes the argument, because like Arnold Schwarzenegger had a BMI over 30 most of the time, and clearly did not have a problem with the health problems that come from obesity. But though that piece of the population actually is very small, that it doesn't work for. But there are better measures, but they're much harder to employ, basically. So one of the good ways to do this is measuring waist circumference. It's actually kind of hard to do that, especially for people who have this disease, and to do it consistently and in the right place. Body fat percentage is also very helpful. A lot of people don't have a body composition scale or access to that. So again, BMI is a start of a conversation, but is not perfect at all. But we can't get rid of it yet because we don't have other tools that are easy to access. We look at DEXA scans and all these different things. First of all, they're very expensive. They're hard to access. And so we have to say, what is our goal? Our goal is to identify people who are at risk, and then to dive deeper into their specific unique features and say, is this a health problem for you or not? So I will tell you, yeah, I'll tell you, my sons are both athletes, but that is not the population we're worried about. But I think it's good for everybody to know that just because BMI doesn't apply to everybody doesn't make it not a useful tool, because that's the argument I'll hear. Well, if it's not perfect for everybody, why are we even using it? Well, I understand, but the other tools are actually much more difficult to use. And we do use them in our clinic, but we have access to those resources that most don't. But it is important to understand, again, does this impact your health? And how does this impact your health? And we see that, again, when somebody's young, their body can compensate for a lot. And so they feel like they're healthy when they might not actually be as healthy as they think. And so what happens is they compensate. And then it's like, I hate to say one day, it's almost that sudden, their body can't compensate anymore. And it's like they fall off a cliff. And literally, like within 1 year, they may have 3 new diagnoses. And they're like, oh my gosh, what's happened? I'm falling apart. It was all already there. It's just the body could no longer kind of hold back the floodgates. So understanding that just because you haven't had a heart attack yet doesn't mean you're healthy. Just because you don't have diabetes yet doesn't mean that you don't have the early signs of diabetes and what we call insulin resistance and things that lead to those problems. So again, that health at any size, true, but we have to really dig deeper into that. And we want to give people the freedom to take charge of their health, and to say, okay, there are a lot of people that honestly would be great candidates for surgery, but today may not be the day for them. They're not ready. It's a personal journey. There are a lot of steps that go into that. So just because surgery may be their ultimate solution, that may not be right now. And that doesn't mean we can't use other tools, even if they're not going to have the exact same result, that can't be beneficial for them. And we need to use all the tools.
Yeah.
Why not? Right? Like, why not use all this? I think that so much of what you said is so validating for so many people. And I also think that it's really important. It's been important for me. And I think it's really important for all of our listeners, with that stigma that surrounds any kind of weight loss surgery, is I think you've done a really good job in the first half of this podcast of eliminating that this is like the easy way out. Because thinking of it in terms of a medical condition that is in need of treatment, I think has just opened up my mind so much to like, well, we would never tell, a person that was suffering from schizophrenia, like, will just be better. Why don't you?
Yeah.
Like, you
At
don't
one
want to be
point we
like
did.
that.
Yeah.
But
We
at
did
one
one
point we
time.
At
did.
one point we did. And all of these kind of, they all come through their evolution, right? Like mental health it needed so much time. At one point, if you had schizophrenia, like you were just put in a hospital and just like be better. Like we will just try all of these crazy things until you can function in society, and not thinking of it as like we could actually treat people to be able to function in society. Like same thing with depression. Like, can't you just be happy? Like at one point, a lot of these things, just, to your point, a lot of these things were so stigmatized. And I think that weight and weight loss surgery is at one of those kind of like breaking points where there's
I
a new
agree.
discussion.
I
I
agree.
hope so.
I hope so too, because I think, and we're going to get into this next, I'm sure, but I think this super excitement around medications is going to help us bridge that gap and help us start to get people to understand this as a disease. So I think this is a unique time in our lives right now. And so I do think this is the time where we can make progress on this, specifically understanding that. So the example too, Rachel, I was going to use is like asthma. So imagine somebody who has asthma. Do we tell them stay home, avoid all your triggers, purse lip breathe, meditate? No, we give them a medication that is life saving so they can experience life and be part of the world, right? So just again, think of it as it's a medical condition that can and should be treated, and there are effective treatment options.
So I want to talk before we talk about some of the new medications, which we're definitely going to get there. They were hot topic questions when it came from listeners. I do want to discuss just first the surgical options, because we had a lot of people that were wondering about nutritional needs being
Yeah,
met. And I know that this is a common question. Whenever we're talking about reducing the size of the stomach in any kind of, I know there are a lot of different options now. I'm not versed on all of them, but I know that, it's not just that we had 20 years ago that we staple the stomach and it's smaller and then you're better. So but I hear from a lot of people the concern of how is my body going to be able to absorb nutrients in a significantly smaller space? And is it possible to have nutritional needs met after surgery? So, do you have any insight on that?
yeah. So again, this could be a whole hour long conversation too, but I'll try to kind of keep it focused. The body is different after surgery than it was before. We've changed the biochemistry, we've changed those gut hormones, and that makes a huge difference. So most folks, and again, they're different procedures, they work a little bit differently, but to understand that most folks will be on much lower calories, but they're not starving because those signals have been changed by the surgery itself, those biochemical signals. So if you have not had surgery and you're trying to go down to the calories that the post-surgery patients have had, you will not do well. You will not experience things the same way they do because their biochemistry has been changed and yours has not. And so that's the first thing for people to understand, because most bariatric patients long term will eat around 1,000 calories long term, forever. And early on, it's way less than that. It's going to be 500 to 600 early on, and then 800, and then 1,000, and then especially some men will be more up around 1,200, but most are going to be between 1,000 to 1,200 for life. That's
My
forever.
goodness.
Yeah.
Wow.
And to
It's
understand
like
that
my breakfast and lunch.
well, and they're not starving, and their bodies are going to do well on that. And one of the errors that a lot of people make is they go work with a personal trainer who tells them, well, you can't possibly exercise on those calories. You must eat more. And that's actually not true for bariatric patients. And that's really important to understand that most bariatric patients can do very intense exercise, for an hour a day without changing those calorie needs at all. At all. So, and that's really important to understand. Now, what they eat becomes very important because the portions are small. So choosing the right foods and the timing on those foods is very important. And that can vary depending on what procedure they had. So if they had a procedure that involves the intestine or rearranging the intestine more, the way they eat changes because if they have too much carb loading at one time, it can give them terrible diarrhea, flushing, sweating. They can pass out even if it's too much carbs all at once. So again, the way that they get those in is different. Definitely we focus on a high protein diet after bariatric surgery, and that's really important for maintaining muscle. But some patients go too far with that and they're only eating protein and they look at carbs as the enemy. We need carbohydrates, especially to exercise. We have to have some carbohydrates. But what kind we eat is important, and what we choose to eat is very important. So those are kind of the underlying principles to understand that one, calorie intake doesn't necessarily have to go up. Now we have some patients, I'll tell you, who've done the Ironman, who've done many marathons. They do, we have one patient who's doing a marathon in all 50 states. We have people who do serious, intense exercise. Now that's not going to be most of our patients, just like it's not most of the population who goes and does an adventure race. That's a small number of people. They need some additional individual tailoring for how they do that level of thing. And unfortunately, there's not great evidence to guide us. This hasn't been well studied in post-bariatric patients. They're just not a population that people like to do research on. Again, for stigma, for a lot of things, we do over 250,000 bariatric surgeries a year. There are a lot of people out there who've had bariatric surgery. It would be wonderful to have better studies and evidence on this. It is a little tricky because, again, it depends on the procedure. It depends on how far out they are. It depends on the level of activity. There's all this depends, very individually tailored. But essentially, you can think about it that when someone's like trying to build muscle mass, they need some additional protein. For maintaining muscle mass, especially in the early weight loss phases, we have definitely a higher protein focus. But there is such thing as too much protein. And that's also something that people don't always understand. And this, again, rough ballparks is going to be individualized to each person. But for general post-bariatric, most women are going to need 50 to 60 grams of protein a day. Most men are going to need 70 to 80. There are some very heavier muscle mass women who are going to need in that 80 range. There are some men that are going to need 100 or even 120. I can tell you I have professional football players who are my patients, and their protein needs are different than some other folks. So there are individual tailoring to that, but those are some rough ballparks. And then if someone's trying to build muscle, actually I have a patient who's a bodybuilder. Usually think of kind of a 20% increase on the protein when you're doing training, not off season, but during training. But the biggest mistake that people make is hearing from a trainer that you can't possibly exercise on those calories, and they increase their calorie intake and then they have weight gain. And if they have significant weight gain, their body's set point will go up, and they're not going to be able to get rid of all of that again. We can get rid of some of it, but they're not going to get rid of all of it again. The other really big mistake people make is snacking or grazing throughout the day. They think that they need to eat a little bit all day long. And actually, that is the number one way to overcome the surgery and gain back weight. So by grazing, first of all, most people eat about an extra meal and a half worth of calories a day. But also because of insulin resistance, when they eat like that, they tend to store the weight as fat. And so it goes against a lot of the nutritional advice that's given to athletes who don't have obesity, about eating small, frequent meals throughout the day and that will bump your metabolism. That is not offset in people with obesity. That is actually the worst advice they can get, to eat multiple small meals a day. They need to eat regularly. They need to not skip meals, especially when they're exercising. And they need to choose the right foods. And they may need a little something extra pre-workout, especially if they're doing high intensity workouts. if you think of beyond an hour of pretty high intensity workouts, if they're doing 2 or 3 hours, a rough guideline, again, it's not going to be perfect for every person, but is adding an extra 100 calories for an extra hour of intense exercise above that 1 hour a day. So if you're doing 2 or 3 hours a day, you may need an extra 1 or 200 calories a day. So it's not as much as people are thinking, but you do need a little bit more. And again, what you eat, the timing of that is actually important. So hopefully that gave you some broad strokes on that post-bariatric patients can be athletes, and many of them are.
Yep.
And it's wonderful. And we really emphasize physical activity with bariatric surgery. It is not going to cause a lot of weight loss. That's the other thing for people to understand, that it does healthy, great things for their body, and it does great for weight maintenance. But unless it's in the early phase after surgery, they're not going to see a lot of change on the scale. A little bit is possible, but not a lot. Another mistake that people will make is, well, I do 2 hours on the elliptical. That means I can have an extra 250 calories today. That's not how that works. That will lead to weight gain. You can't exercise yourself out of those diet choices. Diet really does rule the scale. So hopefully that's some broad strokes without going down too many rabbit trails.
No, that has some great insight, because I think something specific that you kind of keep touching on is just that there are so many different variables, and there are so much that is going into weight loss surgery and pre-care and aftercare, and how the body is metabolizing food, and it just that it's an all-encompassing approach. Because I think that a lot of the stigma surrounding weight loss surgery is that it's just like, well, then they got weight loss surgery and then that was it. And and what you just what you touched on is so many different touch points between gut health, between diet, between exercise, how many calories you can consume, what your protein should look like. There's so much that is going into how you need to change pre and post weight loss surgery, that it's not this just like take the easy way out. It was a one fix and you're done, which I think has been the kind of the most misunderstood idea about weight loss surgery. And I did want to ask, kind of like you just touched on it there, but a direct question from some of our listeners is, she was just wondering if it's possible to follow macros or any type of diet that supports muscle growth if you've had weight loss surgery.
Yeah, so that kind of comes down to that protein again, bumping up the protein, usually by probably 20% if you're really looking to build muscle. But don't go crazy. Like I'll have women trying to do 120 grams of protein a day. And that is not going to work for them, but it's also going to have other side effects and problems with that. There are some dietitians who actually specialize in bariatric athletes. And so I do encourage some of my patients to look at, there's some social media stuff that one of them that works with a lot of athletes has like a podcast and an Instagram site. Those are people who have a special interest and passion in this area. So when you want to be really being an athlete, those are great resources to go to. So, like Active Bariatric Nutrition has some things that a lot of our patients have used. Those resources are out there because not every program. So I have 4 dietitians in my program, and I'll tell you that they do pretty good with athletes, but they're not specialists working with athletes. Versus somebody who this has been their passion. She's worked with athletes specifically for many, many years, has a little more expertise at fine tuning those little individual needs. So when they're really looking at intense stuff, Ironman, marathons, bodybuilding, it can be helpful to be connected to somebody who really has additional expertise in that area. And I really do tell people that all bariatric surgery programs are not the same. And I wish they were. And I work nationally on our accreditation and trying to bring everybody up. That's a big part of my job, is improving the quality across the board, but they're not all the same. And so I tell people, when you're not just picking a surgeon, you're picking a program to support you for life. So if you don't see those resources, you don't see them having a support group, you don't see that team approach to lifelong care, if your surgeon tells you, well, we take care of you for a year and then you're on your own, don't go there, because that is not what this is about. This is really about specialty bariatric surgeons are masters of this disease. And so it's not just we do surgery and you're done. And if you're going someplace like that, that is not probably the place for you. Because to understand this disease, to understand lifelong care of this disease, you can't have surgery and be done, or you will struggle. Because if you don't have all the supporting pieces, we change your body to work with you, but you still have to do the hard work. So when you do the hard work, it works. But if you think you can not make any changes and have surgery and have the same result, that's just not going to be the case. And so I do think you're right. There's a lot of misinformation out there, a lot of misunderstanding. But again, I hope that people will start to understand the lifelong treatment of a lifelong disease. It's a chronic disease that even with surgery, we're not curing. But we are treating it with the most effective tool we have, and we will continue to help you manage this your whole life. And we use medications too, and we use medications pre and post surgery, and those can be extra tools to help us too. So again, it's not surgery and you're done.
I love that you said that. I also, just want to thank you for touching on the ability for bariatric patients to work out at an intense level. We had several questions about whether or not that was appropriate. We also had questions from trainers who were wanting guidance on how to program for their bariatric patients should their intensity level be lower because the calories are less. Like should and I love that we are able to get all of this information out, because it's not only the patients, it's also, the post-care people that are helping them in their life that need to be educated on this. Mm-hmm. So with that, I did just want to jump into, we're going to talk about Ozempic again.
And any other medications that we're not sure about.
Yes, of course, there are now many others, but we keep getting this question. I know people that I interact with on a daily basis that are taking weight loss drugs. I think that it is very hot right now, and it is being thought of as maybe the new bariatric surgery. Like, is this the new answer? And I wanted to give you a minute to just talk about your professional thoughts on, are these drugs effective? Are they the answer? Do we have long-term results with these? What's happening?
Yeah, so this is clearly the hot topic around the country right now. And again, there's so little, I think, general information about how do these medicines work and what are they doing. The science is there, but there's just not a lot of widespread knowledge, I would say, across the public about that. So I'll talk about Ozempic since you brought that one up, which is the molecule is called semaglutide, which is also the same as Wegovy. So just to understand, these things go by different names, but the molecule is actually exactly the same, that semaglutide molecule. So what it is, it's called a GLP-1 receptor agonist, and it works on one of the same pathways we use for surgery, for bariatric surgery. And that pathway is very powerful for helping you feel satisfied with small portions, tempering hunger that comes with the reduced calories, because I should have explained this with the disease of obesity. The people who have obesity, the body's natural response to that calorie restriction is to vastly increase hunger and to slow down metabolism. And so someone can eat and literally 20 minutes later feel hungry, feel like they're really, really hungry. And other people who don't have this disease will look at them and say, how is that even possible? Like literally you just ate 20 minutes ago. But that's how powerful these hormones are. And they drive people to look for food. And there's lots of different actually pathways. So GLP-1 is one of them, and it's one of the really big ones. And it's also related to type 2 diabetes. So that's why it's such a powerful target. Now, with bariatric surgery, I'm actually hitting like 20 pathways, not just one or two. So I tell people, with surgery, it's like operating with a sledgehammer. I can hit a lot all at once. And with surgery, actually permanently change that biochemistry. But I'm only changing about 2/3 of the connections between the gut and the brain that we know of. We'll learn more all the time. But that means 1/3 still aren't normal. And that's when I say the disease is not gone. It's treated, but it's not gone. And your body is going to want to continue to keep pushing you up your whole life, but we're able to control that better because of how much control we have from the surgery. So for the medication, it's targeting one of those same pathways, that GLP-1 pathway. It's a gut-brain connection, and there are direct receptors in the brain as well. And when I told you bariatric surgery directly impacts the brain, that's part of the pathway of that. So with this medication, think of it as getting a synthetic hormone to help with that receptor in both the gut and the brain. And while you're taking the medication, it can be very helpful, but it's limited at how far it can go, because that's only one pathway of many pathways that impact this disease. So it's helpful, but it's limited in how much it can do. And that's where like the next generation of medicines, tirzepatide, which is like Mounjaro, Zepbound, impacts 2 pathways. So it has a little more power, but it's still nowhere close to the power of surgery, is what I will tell you. And it doesn't replace what surgery can do. But so we give you a synthetic hormone that helps while you're taking the medication. It does not change the underlying biochemistry. It does not change the underlying disease. So think of it as somebody who takes blood pressure medicine and it helps their blood pressure get better. Their blood pressure problem isn't gone. It's treated and controlled. But if they don't take the medicine, boop, their blood pressure is right back up. I didn't take my medicine today. My blood pressure is high. That medicine is needed to control the disease actively, but it's not changing the underlying disease. That's what these medicines are. They're helping control the disease, but not changing the underlying physiology. Now, with somebody with very early disease, basically bringing them back a couple steps makes a huge difference, and really can bring them closer to that normal state. But again, it only works while you're taking the medicine. And what the studies show is when you come off the medicine, those basically hunger pathways, those satiety pathways, those metabolism pathways go back to the way they were. And so about 2/3 of people will gain back, or I should say most people will gain back 2/3 of the weight in the first year. Almost 100% will gain back by 2 years of coming off the medicine, because their body still has the same problem it had before. And they're working their tail off. They're doing everything they can do, because the problem is with these medicines, a lot of people think, well, I just need a tool to help me, and then I will learn to eat right, and I don't need that tool anymore. Well, I'll tell you, most of those people already knew how to eat right. Their body was driving them. And so people who've been on these medicines will tell you, it's amazing. I don't think about food. Like they call it food noise. Like I'm not hungry, I'm not full. I just don't even think about it. And before I was always thinking about, okay, when's my next meal? I need to be planning for lunch. Like, even though they may logically know that food isn't scarce for them, they feel it in their body, like they may not eat again. And that is literally their physiology driving them. And so what I discuss with patients and the public is, if we can control physiology, we can control behavior. So when you're not thinking about food and your body's not driving you to look for it, it's way easier to do meal planning, to go do your grocery shopping, to not do that impulse buy in the checkout lane, because your body is literally like, nah, I don't care about that. And I tell people it's a little bit like trying on what it's like for people who don't have this disease.
I
You
was
know,
going to say that. That's what I was going to say. When I hear from people that potentially have this, they always report the same feelings of that food noise, and always thinking about it, and always talking about it. And it seems very distracting to me,
oh,
because I'm like,
absolutely.
we weren't even talking about that. Or like, why are you thinking about, like, it always seems like something, and I think that's why sometimes people without the disease do not
Right.
understand,
Because they do not have those same feelings.
is we're not
It's not the
thinking
same.
about that all the time. But if we were, then we would, I mean, you
And
think
that's
about
what we
red stop
see.
signs, you see red
Yeah.
stop signs, you know?
Even with these brain hormones, the way they connect with the brain, there's something called fMRIs, which are functional MRIs that show what areas of the brain light up. And there are reward centers, and different people experience different rewards even from different foods. So some people are like, sugar is a real problem for me, and you can see that their brain reward centers in the sugar area are like, whoa, really loud, and other people's are like minimal. And I can tell you, even between my two sons, one of them can literally eat a bite of cake and walk away and never ever think of it again.
Yeah,
The other
that's funny.
one is like a raccoon. Like if there is sugar anywhere in the house, he will find it. And his body is just clearly built different. They're both athletes. Neither one of them have a problem with this disease, I'll tell you, but they're clearly built differently. And the way they experience those rewards is very different. And you look at them externally and say, well, neither one of these guys has a problem. And I totally agree, but they still experience the world very differently. And people with this disease experience the world very differently. So, like for Ozempic, it's working on a gut center and a brain center. And we have other medications like phentermine, topiramate. They work on those brain reward centers and cravings rather than the gut GLP-1 pathway. So there's a whole bunch of different pathways. And we have about 9 medications in our toolbox right now that we can kind of put in, put out, put combinations together depending on what an individual is struggling with. The GLP-1s are the ones that have the big, splash right now, but we have other tools as well. But all of them are controlling a physiology, not changing a physiology. Now, with surgery, we're actually changing that physiology permanently. Now, having said that, not everybody responds the same to surgery either. So it's what we call a bell-shaped curve, right? So you talk about the average folks that expected response. We have some super responders. I'll tell them, oh, I expect you to lose 100, 120 pounds, and they lost 200 pounds. That's not everybody. Those are the super responders. And then we have the partial responders who didn't lose as much as we would have expected. And it probably has something to do with their genetics and their receptors and their hormones and how powerfully those things are being turned on compared to somebody else. So this is what we are learning more and more about bariatric surgery and the variability of response. And we can fine tune that response oftentimes by adding medications, depending on an individual's response and looking at these pathways and where do they struggle. So again, this is the importance of lifelong care, is understanding if they're not having the response we are looking for, we have options and tools to try to fine tune that. And in the future, little down the road, we'll be able to test somebody ahead of time and say, okay, you have an FXR4 receptor. That means you're going to do really well with the sleeve. And we can add this medicine and these things. We're not there yet, but that's where the future is much more tailored individual treatment. Right now, again, I'm operating with a sledgehammer, which is super effective, but still not perfect, and we can always do better. So I tell people, this is the state of the art today. You come talk to me in 5 and 10 years, and I'm going to have more tools, and we're going to be even better at this than we are today. But getting more and more of the public and patient advocates and healthcare providers understanding this disease and being ready to invest in learning how to do this better. Cancer has 50 years of research on us. We're way behind the understanding of cancer, and we need to get there with obesity. So, long story short, Ozempic and those medicines are working through 1 or 2 pathways. There's a new medication that'll be coming out that will work through 3 pathways that will be better than the 2 pathway one. It's not out yet, but all these things are helpful to us. And they're especially helpful when you're early in the disease process. Those are the people who benefit the most. The problem is a lot of people think that those medicines should be used on people with really severe disease. And again, I told you the medicines are limited in what they can do. So the same thing I told you, like where people are like, well, I want to be 150 pounds. And they're thinking this medicine doesn't work because I only lost 25 pounds. That's the best that medicine can do for you, working on that one pathway. It does work. The other thing is a lot of people don't stay on the medicines because they don't understand them. They don't understand how to work with the medicines. They don't understand how to what we call mitigate the side effects. And a lot of the side effects come with not understanding the medicine. So if you are on, say, Ozempic, since we're talking about that one, and you try to eat a big portion, you can get sick. You can have nausea, vomiting, and diarrhea. And if somebody doesn't help you understand that the whole point of the medicine is you should be able to shrink your portion size down by about half and be fine. It's people think they just didn't tolerate the medicine, but in fact they were overeating the medicine and having the expected side effect we would expect when you're not essentially working with the medication. So again, the big danger too is when people are getting a medication without any of the counseling and support that need to go with that, and the nutritional support, understanding risk of protein or need of protein to risk of muscle loss and muscle wasting, and the importance of exercise in preventing muscle loss. It needs to all go together. So again, when people look at just like the surgery, the medicine as a quick fix, they're going to struggle and they're not going to have the result that they should. They're going to be frustrated. And yeah, they can have muscle wasting. They can have a lot of problems actually if they're not having appropriate support for those. I am so happy that we have these medicines because for years we had very little to help us. And diet and exercise alone, by the way, is only effective for people with severe obesity 5% of the time. It's abysmal. And so most people overestimate how effective diet and exercise is alone for people with severe obesity. It's great for somebody with has a little overweight. That's very different for somebody who has severe obesity. And so they overestimate how effective non-surgical therapies are, and they overestimate the risk of surgery. And they're afraid of surgery. And they think it's just for the worst of the worst. Like they watch My 600-Pound Life. Yeah. And they think that's not me. I must not need surgery. So lots of misconceptions and myths. But hopefully, did we get to the question on Ozempic and how does it work? Just to summarize, it's a synthetic hormone that works while you're taking it. It doesn't change the underlying disease. When you stop taking the medication, the disease goes back to the way it was. Now, there are things we can do and strategies that are coming to try to help people who've lost some weight and trying to maintain it. And we may stagger the doses or switch you to a other medication like metformin or phentermine to try to flatten that curve. The weight gain will still be there, but maybe we can make it 5 years instead of 2 years or things like that, especially with early disease. So there's lots of strategies. Again, when you work with specialists who really work in this space, there's lots of options and strategies that usually don't come up to people who are just getting an online medication and no additional support.
Yeah. You know, I really love the entire explanation of medication in this sense, in just the different avenues that you can take. And I can't help but draw parallels to mental health treatment that has been, historically misunderstood, and we have a better understanding of it now, but specifically depression, and just allowing people with some of these diseases to experience life how people who don't have those diseases are already functioning on a day-to-day basis. Like, when I talk to people about depression, I'm like, it's not a cure, it's not an overall cure, it's not you will never feel sad again. We're trying to bring up the basement that you hit to just a normal sadness level. A functioning level. And it's a tool in your toolbox. When you go off the medication, it's not just all of a sudden you have it for the rest of your life. If you go off your medication, then you lose that tool that you've developed, and you will go back to, for a lot of people who are suffering with depression, will go back to suffering with depression again. It's not that you can't just start taking the medication and all of a sudden you're cured. Almost.
You learn to be happy.
Yeah, you learn to be happy because you experienced it during this like certain portion of time, which I think like you did a beautiful job explaining with, like, people hope to learn to eat right, and then for the rest of their lives, they don't have this disease that is already ingrained in that we've treated for a certain period of time, but is not an overall fix for the rest of your life.
Yes.
It's kind of a misunderstood at this time, but I think we're doing a lot better, and I hope that
I would agree.
conversations like this can really open up just more conversations and the eyes for people who are supporting someone in your life who struggles with obesity, or you're a trainer, or you yourself have struggled with obesity and are wondering what are the type of treatments for you, and diet and exercise hasn't worked for you. We hear so many women come with heartbreaking frustrations that they have done this their entire lives. You said as
Exactly.
early as the age of 3, that as a society, we told them they need to work harder. They need to just be better. And they're coming in they're screaming with these frustrations that like they have done that
Yeah,
and it
exactly.
hasn't worked.
Dude.
And then on the flip side of that, like a lot of us in this space have called them liars. You must not have been working hard enough. And I'm sure that continues to lead to the stigma. So I think this conversation is really helpful for us. I think we've dove into a lot of things here. I definitely think we could spend an entire another episode, but I think that we've opened up the door to maybe having some of these conversations and just thinking about obesity and weight loss surgery in a very different way. And not only weight loss surgery, but weight loss treatment in a very different way, that we can start to just unpack that a little bit more.
Yeah, and I just was going to make one other comment because unfortunately, access to these medicines is difficult. And for a lot of patients, it's getting worse. So a lot of patients had coverage and their employer's not covering it anymore or different things like that. And that's very scary because you can imagine when they finally felt normal,
Yeah.
and it's terrifying to think of going back. And, we're constantly advocating on a national level for coverage, and we need better coverage of these medicines because they're an important tool. But I will tell you, even for people coming in for surgery, most of them now have tried medications before they come to surgery. And a lot of them, one, realize that there's limitations to the medicine, or they don't want to be on them all their life, or they don't have access to them anymore. But it's been a step on their journey to say, now I'm ready for surgery, because now I tell them it's a little bit like trying on surgery, to know what it feels like to not have those constant thoughts. And I tell them it's not going to make you not want to eat ever again. You're going to see a commercial and you're going to smell something. There's so much in our society, right, that also plays a role in the environment, and that stuff is still going to be there. But it's so different when your body is working with you. And if we control physiology, we can help control behavior. And then that's where the true change, and I tell people it's a life transformation. You feel like you got your life back. Like you always knew this person was in there. Nobody else maybe knew it, but you knew this person was in there. And it's truly, it's like a butterfly, coming out of a cocoon, and it's a wonderful, wonderful thing. But I do think more people are willing to think now about surgery in a different way because of the medications. And I just hope, again, that it continues the conversation of understanding that you didn't do something wrong because you're coming to surgery.
Yeah.
You're coming to surgery because you want to live more years and better quality of years. You want to be there for your kids. You want to see your grandkids. You want to be able to do those wonderful things that you haven't been able to do. And so really that's what this is about.
What an amazing, amazing way to frame that, and so different than how it has been framed.
Yeah.
And I've learned an immense amount from this episode. And I really can't say that often. We've done this for 5 years and we've interviewed a lot of people. And I'm floored by all that I've learned, and the shift that you have created in my mind of opening up the possibilities of do we treat people better, and that every single person deserves it. And I want to just thank you first of all, for coming on and your willingness to get this message out there. And I also want to thank you for the incredible impact that you've had on so many individual lives, all of the things that you've done, all of the people that you've seen blossom and come out of their cocoon. And it's really thanks to you being open and guiding them on this journey of like, Shame's over there and we're not going to talk to her anymore. We've had enough interactions with Shame. Let's try this instead. And I love you for it.
Well, thank you. This is obviously my passion. This is my calling. It's not just what I do, it's who I am, and it's truly my pleasure to do this. So
Thank you so much. Can you just for some of our listeners, we're gonna put your information in the show notes and try and get them to be able to hear more from you. But is there any other resources, or I just want to offer you the opportunity for different ways that they can find you or maybe get in touch with
sure.
you, that they could, after this episode, maybe have some more questions?
Sure, absolutely. Well, I'll tell you, of course, through the practice website, there's UnityPoint Clinic Weight Loss, but it's also icanlose.com. But there's lots of stuff. If you Google me, there's lots of different interviews and stuff I've given too. But truly, I mean, even email is a great way to get a hold of me. I do a lot of work with a lot of different groups. So Obesity Action Coalition is a patient advocacy group that I work with a lot. It's about the lived experience of the patient. So that's a great place for people to go. The ASMBS website, which is the American Society for Metabolic and Bariatric Surgery, which again, I'm a senior past president for, has a patient portal entry so that they can find resources. And there's like a find a surgeon profile. So if you want to find a surgeon, and especially in your area, you can find that. I do recommend when people are looking at surgery to do some research, because truly not all programs are the same. And you want to find a program that's aligned with your goals and needs to in mind. Those are two of the top places I would go. Again, like I said, there's some places that I know my patients really like the Active Bariatric Nutrition. There's a Instagram, same thing, like Active Bariatric, for people who specifically are looking for athlete guidance that they may not get in their home program. That can be really helpful. But there are a lot of tools, like especially if the ASMBS has it out there. There's the Obesity Medicine Association, which is the medical side of things. I'm also a member on that side of things. They also have a lot of resources too. But for patient advocacy, I think that Obesity Action Coalition is a great place to go to get a start, and the ASMBS website too. It is a journey, and there's a lot of stuff out there, and not all the stuff is going to relate to each individual. That's the other thing I say is you're going to hear a lot of crazy stuff out there.
Yeah.
You know,
In every aspect.
yeah,
Everywhere you look, there's always good information and bad information. I tell people that with therapists, like, because you've tried therapy one time doesn't mean that you are
exactly.
just done with therapy. Like, there's so many great therapists. There are so many great different ways, and there's bad ones too, like, or that
Exactly.
aren't for you.
Find somebody exactly that is for you, that is a match for you, that has a passion for you and your care. The number one source of people who come to surgery are from happy patients. They send their friends, their family, their coworkers, but not everybody has that resource. And sometimes their primary care doctors aren't talking to them about that because they're not comfortable with it. They don't know what to say. So most people are doing their own research on this instead of through their primary care provider. So, but definitely do a little homework. It does pay off, and look for a program that really supports you lifelong, that has the resources to do that, that is committed to do that, and someone that you connect with, that you have passion with, that you can trust to help you on your journey. Because I can tell you, I don't do this alone. I have a fantastic team. I could never do all of this by myself. And so that they're key in this success.
Well, Dr. LaMasters, we just thank you so much. We're going to put all of those resources in the show notes so they're quick clicks, and our listeners can have access to them. And it's really just been honestly a pleasure. And I just want to thank you again, for the work you've done, for coming on. It's been wonderful.
Well,
Yeah.
thank you. And maybe we'll get to see you again sometime.
Absolutely.
Absolutely.